more on the Obamacare discussion on Informed TV.
$1 million uninsured into the system, which, God bless them, they're going to need the care. But we're going to have to come up with some way to try to keep those costs down, or we're going to be in trouble. And frankly, the Affordable Care Act doesn't do that. I mean, it doesn't look at costs, and that's a concern. And I think most experts would agree that, we got this through and it was passed. The cost could just explode for a variety of reasons. One of them being what Chuck and Steve are talking about is that we have this expectation to get everything, and the most expensive thing is the ones we want the most, And if everybody has the right to it and there's really no financial barrier to it, the demand could be tremendous. So that's what I would, does that make sense to you?
There are built-in barriers.
Yeah.
They're looking at hospital initiatives to look at quality of care, looking at are they following appropriate guidelines. If people are no longer using the emergency room as their primary care providers, that becomes less of a burden on the system. If the people that are getting better care are staying healthier, then they're more productive. That adds to the GDP in the system, because now you don't have that drain with people out ill all the time or not be able to get to work, those types of things. So there are costs looked at in the law. Is it work out perfectly? Probably not. I can't say I fully understand it myself, but there are ways to try and reduce the cost.
Part of this, part of this cost thing is that there are the 15 million uninsured, but they get health care. I mean, if they're in a car wreck, a motorcycle accident, they get health care. But the cost problem is that they're going to get into the system, and then they're going to demand all these extra things that get out in the periphery. I mean, all of the preventive tests, I mean, there's some that have been shown to be cost effective, but the vast majority of them, if you read any healthcare economics, they don't save money, they cost money. They save lives, but they don't save money. And so there needs to be some rethinking, in my opinion, of some of the many, many preventative measures out there that result in unnecessary tests, unnecessary surgery, et cetera, et cetera. But at any rate, the cost thing is tremendously complicated. But one of the reasons why I support this whole concept of this bill is that when Bill was at the hospital, he had to take care of people in the ERs. I mean, Steve, we've been there. You can't kick them out. They walk in, you've got to see them. And so they get care. And so in theory, if they had a health plan, they could see a doctor, they could get more appropriate care in the right place. But we have a huge problem in this community, in these counties that I'm dealing with, Prime West, the number of the Medicaid people that go to the emergency room, because they just do, and that's the behavior pattern they have. And we got to do something about that. But
I believe Prime West deals with 13 counties?
yes, 13 counties.
13 counties. John, you're on.
Chuck answered my question. Bill, you were talking about the 50 million or whatever, but the response was to you was, well, what about those people that are going to emergency rooms anyway? And you responded to that, so.
I mean,
I
are they
see
going
there's
to
still a
get
drain.
all those drugs out there that don't do a damn thing? I mean, I'm unhappy, so let's give you 3 antidepressant medications, which frankly really don't do a lot, except for a certain small subset. I mean,
There's vested interest all over
everywhere.
so.
Yeah, there's a reason why they do twice as many spinal surgeries in this state as they do in other states. It's called Medtronics and a few other people, and there's all kinds of problems.
Tom, you're on.
To any of you, what would be the difference in cost between the Affordable Care Act and if we did go to Medicare for all? Would there be a cost savings in Medicare for all? And then what would be the main obstacles against that besides the healthcare companies?
Well, I think from an administrative standpoint, we know Medicare very well. And it's probably, they say, in fact, the president said last night that the administrative cost of Medicare is much lower than any other insurance company.
And you'd only be dealing with one.
But when you talk, when you talk in terms of Medicare to physicians and hospital administrators, we know what you're talking about. It's just, okay, let's expand that then to the full population, use the same benefit base that we have for Medicare. And pregnancy is covered under Medicare, by the way. Did you know that?
So what's
We don't have many on the client. But we know what that is. And we we know how to administer it. And we
So
know
what's
that,
the,
we
so
know
what's
the
the
payment
barrier?
mechanism.
The
We
barriers,
know-
the health insurance companies then?
Pardon?
The barriers, the health insurance companies
Well, I
then
think
that are
there's
prohibiting us from going
politics,
there?
there's probably a lobby there that people don't want to touch or whatever, but that's on both
'Cause that
sides.
was brought up during the debate
Yeah,
over
I
the
think the
Affordable
politics
Care Act or
complicates
whatever.
everything. And,
If they are considering the Affordable Care Act, a government takeover of medicine, when it's all done through private insurance, no government program because that was voted down, what happens when you try and make it all Medicare? I think certain people will probably go through the roof.
Until you explain to them that Medicare is a government program that they're on and enjoying.
But Medicare, Tom, you know, again, it's back to the benefits, back to counseling people about end-of-life care so they don't
You
spend
still
so
got
darn
that.
much money that last month they spend in the hospital unconscious. I mean, they still got to address the benefits. And, I mean, Medicare is a fine program, but it's, and the legislature won't let them. I mean, I think some organization, non-elected, I don't care what Romney says, independent, intelligent, hopefully, well, okay, that's
And
not
then-
the government.
and then
all right, sorry.
any
But a
restrictions
group
you put
of
on your
people
death
who-
penalty.
we got to rely on somebody to make these
Oh, yeah.
decisions. And they got to be based on cost efficiency. They got to be based on cost, not just whether they work a little bit better.
Cal?
You're talking about cost, infrastructure, without getting anybody too wound up, but there's a county just west of here, they're sparsely populated. They've got $24 million in grants and guaranteed government loans for brand new hospital. And I remember, I was there a couple of years ago, they had a handful, 2 or 3 patients. They probably won't have much more because the farming communities are getting smaller all the time. Does that make sense to you?
No. That's another pet peeve of mine. When, Bill remembers when we got the DRGs, the diagnostically related groups,
no,
and prospective
Wait,
payment.
no, DRG stood for the revenue's gone.
Well, you did all right the first 5 years or so, believe me. You did real well. At any rate, because of the effect that had on the small rural hospitals, they started, you know, they created all these critical access hospitals, where all the hospitals around us, except for Douglas County and Brainerd and St. Cloud and Wilmer, you know, they are critical access hospitals. They get paid on a per diem basis. And, you know, they're expensive. And they're expensive because the local communities, just like the school and the post office, you close the hospital, the school, and the post office, you might as well roll up the town. But I personally think that that's going to change, and that a lot of these little hospitals are going to have to close. And because they're too expensive to keep them all open. And that's another change. And I, frankly, when we talk about, Bill talks about all the baby boomers, I kind of think a lot of them would make great nursing homes.
Yeah.
You know, they got kitchens, they got all kinds of facilities.
You know, long-term care,
But
I mean, talk
sell that
about
to the board in
Yeah.
Polk County or said or whatever, you know.
Lorno, you had your hand up.
Well, I was just thinking that our system really didn't need fixing. I didn't think. I mean, I thought we had a pretty good system with Medicare and your supplement insurance. Kathy had a kidney problem and she was on dialysis for 1.5 years, and we never saw one single bill for that. She had a kidney transplant and it costed us $600 or something like that. I kind of wondered whether I really should have had to pay that even with our supplement that was supposed to cover that. I mean, a very expensive situation anyway, but at any rate, I thought we had a pretty good system that didn't really need fixing. You're right. I don't know, but I just.
For seniors, it work fine, but if you're young, it wouldn't work fine.
54%, 16%, and what's the balance? 30? 16% is the uninsured. I just looked this up today. If it was right, what I looked up. 54% is provided by an employer in some form or another. Employer, you got it? People working. And then 30% are government provided. That makes sense to you? This was small for what I thought it would be. It still, I think, equals 50 million people, but it's smaller than I thought. This is the one that's really getting crunched. a lot of the uninsured are, you know, I don't know, you'd have to really look at the statistics to see what this really composes of. Are they people that don't want to buy insurance, people can't buy insurance? Probably most of them are people that can't afford it, you know. And that's the ones we're trying to focus on. But why then are we pulling all these people into the same deal? That's an issue that's been talked about. And you know, so these people are, you're saying these people are pretty happy maybe, huh? Is that what you're saying? This is Medicare.
Guy in the blue shirt up there. Had your hand up next to Kevin. Kevin, go ahead.
You're looking at some of those, though, you've got the three groups, but there are some groups that are self-insured. But right now, their premiums are $12,000 to $15,000 a year.
I agree with that.
And that's where it's got to change.
Right.
And I agree with you, Medicare for everybody, completely.
Yeah.
I mean, and a way to finance it is like you said, government, your tax.
Something has to be done, I agree with you. But I was surprised when I saw these statistics, how that all kind of sorted all out. But you know, what you're saying is in here, there's some people that are paying a fortune.
Yes, absolutely. They're paying this major fortune.
I agree with that.
You know, it clearly has to change, but who's willing to change? Douglas County Hospital's got a couple bonds they've got to pay for. They're not going to give up a lot of revenue if they don't have to, not to pick on Steel. I mean,
True, they're costs,
you know,
huge costs.
that's a beautiful hospital. We're really fortunate to have that facility, but it costs money. And those costs, the bank's not going to forgive, or whoever bought the bonds aren't going to say, that's okay, keep it. The average kid coming out of medical school today is like $180,000, $200,000 in debt. And, you know, is he going to go work for nothing or for less? I just had a long conversation with a couple I met in Europe, and they were both, one was a fellow, which is postgraduate, and one was a resident at UCLA Hospital. They both graduated from UCLA, and I just asked them if any of their peers, any of their classmates, anybody they knew in their realm, were going to go into primary care, as Steve alluded to. They did not know one person, either one of them, that was going to go into primary care, you know, internal medicine, pediatrics, family practice. And, you know, they're out there, and the use, you know, the demand or the supply creates a demand. And so there's a lot of specialists, and they get used. And they're not about to say that what I do isn't any value. I mean, a good example is cardiac stents. Stents are very expensive, and they help angina short term. They don't save one life. They don't extend anybody's life, and any honest cardiologist knows that. But we pay billions for those every year. That's the kind of thing where you need this comparative effectiveness. I mean, find out and get that information out there. And don't let the people who are providing the service do the research and say this is what's good because, I got a vested interest in it, and I you know, have as much confirmation bias in me as anybody else, you know. We need to get out from under that. And that's where the cost thing is.
Over here, please.
Yeah, I dispute your statement on stents do not save lives.
Well,
Save mine.
yes, I wouldn't argue with that. And that brings up another good point to this whole debate. There's two ways of looking at healthcare. There's individual healthcare. We as individuals, I mean, for us, the demand for healthcare is what economists would say is price inelastic. In other words, it doesn't make a damn bit what it costs. If you need it, you want it, and you should get it. That's the thinking for the individual. But this health reform business has to address population health. I mean, what's best for the country? What's best for the community, the whole? Now, here's an individual who no doubt the stent saved his life, although he doesn't have a control. I mean, you're one. So if you've been two of you, you know, I mean, not to pick on you, but you lived through it, but what would have happened if you hadn't? The evidence says, well, and I understand that feeling, and that's the feeling, but the evidence, the medical evidence is that statistically, they don't save lives. People don't live longer after stents. They get rid of pain right away, and that makes them feel good. And it's like all of the unnecessary prostatectomies that have been done. I mean, you talk to the guy that had the prostatectomy, the doctor's a hero, saved his life. You know, 14 or, 1 out of 14 of those about 14 or 15 men have a prostatectomy because of early cancer, or what they're calling it cancer.
Because of PSA.
PSA is elevated, the biopsy shows something. Only 1 out of 14's lives may be saved. I mean, we do mammograms on women. You have to do take 2,000 women to do a mammogram on them every year for 10 years to save a life. That costs a lot of money. And out of those 2,000 women who get those for 10 years, hundreds get false positives. They get scared hitless because the doctor calls them up and says, you've got something wrong. They get biopsies. And even a fair number of them get unnecessary mastectomies, because they have early, borderline, whatever. So that's where we need more research, not done by the people who are selling the product, but an independent entity to help us evaluate that.
Yes, it's over here.
All of these people that haven't been getting care because they aren't insured or can't afford it are going to put a load. And then all of us now that are getting older and historically will need more care. Who's going to provide the care? Is there, what are some new ways to do that, to give more care? I think you mentioned nurse practitioners and physician assistants and more kind of triage at a different level possibly, and more health education. But whose responsibility is that? Is that the school's responsibility? Is it hospitals' responsibility to say we need this kind of staff? Or the clinics?
I think it's pretty well known. I don't quite understand your question. Are you asking? Clearly, we need ancillary providers. I think we need a much larger role for public health than we have. I mean, you can't ask Steve to treat the 300-pound people in his clinic. I mean, he can talk to them, but I'm sorry, Steve isn't going to do much for them. But public health may be starting earlier. I mean, you disagree? So I think we need a much bigger role for public health and more ancillary providers.
So those are jobs. That's a good thing, right?
Right and wrong. They look at the, as we're adding jobs now in this slow recovery, they look at the bright spot of healthcare. We're adding healthcare jobs, but all the healthcare jobs you're adding cost money. And that puts more to the GDP percentage that's going towards healthcare. So we say we don't want to put more towards healthcare. We need to make it less, but we need more people doing it, which drives the costs up.
Yeah.
And then you're back into that same conundrum. How do you get more people into healthcare? And for every person that you hire as a primary provider, you have several ancillary people, staff that have to do the billing, staff that in the hospital for the other nursing personnel, that type of thing. And that all adds up more and more cost. So at the same time you're trying to provide the extra care, you also have the issues of the cost of providing the care. And then when we look at a Medicare for All issue, there's discussion now of a 30% across the board cut in reimbursement from Medicare. So when we say Medicare for All, that might be good, but then you have certain fixed costs of providing the health care. And if you have 30% of your coverage is from Medicare, and they give you a 30% cut in your costs, in your reimbursement, as is currently being suggested, where does that go? It's totally enmeshed. So we're kind of moving somewhat away from the Affordable Care Act issues because we're getting the whole thing. This is a attempt to try and rein in costs on whether it does or doesn't. We don't know. We don't know what kind of improvements in cost from health insurance exchanges is going to be to lower people's individual costs for small businesses, for individuals, from that $15,000 a year can find a group plan that might be less. But again, they'll come into the system now with their new insurance, and who's going to be there to provide it? There's not a lot of emphasis in a lot of states for providing primary care education. Duluth residency program, if you don't come from a rural place, they will not consider you. They only train rural health practitioners, but that's few and far between. They're looking at trying to have advanced practitioners that have independent practices where they don't have to be, under the auspices or with a collaborative agreement with, other physicians. trying to expand it that way, but there's, difficulties along that line. It is a conundrum, no doubt.
That, like, again, if we had Medicare for everybody and there's a coincident decrease in the payment, already on both coasts, it's really hard for Medicare, for people to get appointments that are on Medicare and certainly on Medicaid or, welfare. And you lower the fee, that number's gonna drop off. I mean, again, they can open it up for everybody, but there's not everybody out there to take care of people. I mean, there's a
That'll
problem.
happen. That'll happen. There'll be, because if you don't have enough physicians or enough providers, then the cost of that's gonna go up regardless, even if they're not reimbursed at that level. So what'll happen is they'll just not take insurance. It'll be cash only, and then only people that can really pay or wanna pay more are gonna access it. And that'll probably happen. That's why you have people from Saudi Arabia coming to the United States for care, because they can't get it in their own country, and this is the best care in the world, it's the most highly specialized area. But if we can't have that anymore in the United States, wealthy people from here are gonna go elsewhere for that care. They'll find it, that somebody will provide it.
India.
Kelly, you are up.
Yeah, I just had a question. Dallas County Hospital is one of the very few county-owned hospitals in the state. And I heard Romney last night say, like you were saying, we're cutting rates, physicians and hospitals are gonna deny care. Having county status, taxpayer owned, can you deny Medicare coverage?
No,
You can't.
no, in fact, we can't deny any patients.
So they can't deny the bank either.
No, but we can't deny the bank, you're right. A lot of times over the years said, well, this is it. They can't afford, they're cutting us again or doing something. I say, I'll give them the keys, let them run the place.
And they can
Well,
have
the
it,
government doesn't want to do that.
they can have it Northwestern or something that's private, they could deny it.
But I didn't hear that, what do you think?
Not if
Well,
they
you
receive
made it
federal
sound like
funds.
it's not
They're
just
receiving
providers
federal
that can
funds,
stop
they can't.
taking patients, it's also the hospitals themselves.
No, I think hospitals have a hard time, but there are practitioners that, not so much in Minnesota, you don't hear about it, but in other states that just they're not gonna take Medicare
Oh,
anymore.
yeah.
That's gonna happen. I mean, I don't know if it's gonna happen in Alexandria, but you're gonna see that happen.
Matter of fact,
Ken
they tell you
Howell
that
back
when you
there.
call for an appointment.
You heard last night, and you hear it in a lot of health news about the innovative things that places like the Cleveland Clinic, Johns Hopkins,
Right.
Kaiser Permanente, Mayo, the innovative things that they're doing to bring down costs and to treat patients. What are they doing? And are these things that we can do here?
That's a different way to look at it. When we talk about Mayo Clinic reducing costs, when people that are in the practice, that's kind of a joke. Because they repeat everything that is done. You send somebody down there and you've done a workup and you just need some additional care, they'll just repeat it all again. If somebody's had a CT read by the radiologist at Douglas County Hospital, they will have one of their radiologists read the CT for additional cost. So I'm not sure that we're seeing a lot of innovation there. They're
And
talking
probably
about.
redo the test.
Oh, no,
In
no,
addition-
they sometimes will
They
use the
will.
disc
Okay, yeah.
and then reread it, add an overread,
Yeah.
and make sure that their physicians agree. Will that improve care? We're not sure. Usually when you look at their overreads, they're not that different than what Dr. Guzman reads. So I'm not sure that we're seeing some of these larger places reducing costs. I'm not sure if that's going to be a top-down approach. I think you need to see reduce costs from the bottom up. In primary care clinics, that type of thing, really addressing the issue. One of the issues that's a problem is that you have a 10-minute visit, maybe a 15-minute visit, and even in the setting of antibiotics, it takes a whole lot longer to explain to somebody why they don't need the antibiotic than to just give them the antibiotic and get on to the next patient, especially if you're behind. Hopefully that doesn't happen too often. But even in something as simple as that, you don't have time in a visit to explain why they don't need that test or this thing done.
One thing, just to answer what Ken said, there are places that are operating at less cost, but those are fully integrated. In other words, the doctors are employees, everybody works together. Now, part of the PPACA, the Affordable Healthcare, is to create these accountable care organizations, medical homes, and all that. And so that's an attempt to insinuate that kind of integration, teamwork, if you will, through a greater area. I personally think that's not going to work in rural Minnesota. at least not for a generation or two of doctors, because they, they grew up independent. But again, the new changes with Steve, with the Alex Clinic and the hospital, there's a little more integration there, so that may have some impact on cost. But there are places that are integrated and can control the doctors and control what they use, rather than the independent doctor on the staff that does whatever the hell he wants. He's got privileges and he's licensed, okay? So that approach is working. Intermountain Healthcare in Utah, 15% C-section rate, national average 33%. And, they get all the sick babies like everybody, the complicated cases like everybody else. And so the approach can work, but it can only work in certain places. It's not the answer for Wilmer or wherever.
Gentlemen way in the back, and then Jenny, and then Cal, okay? Go ahead.
Talking about the cost of healthcare, I'm curious what the effect of frivolous lawsuits for malpractice add to the cost of healthcare. Anybody have an idea what that would be?
I don't think anybody knows, but it's talked about a lot. And Steve and I'm sure have had times where we've done things in our practice where we better do that. We don't think it's that, but we better do it. And so it's a factor. But I don't think anybody, there's reports out there that say it's not as big a contributor to cost as you think it is. Personally, I'd opt for a no-fault malpractice insurance where every doctor sent $20,000 somewhere and they just had a board decide the cases and get the damn lawyers out of it. But again, we don't really know. Part of the thing that sticks in my craw with that kind of question too is it's very convenient. I'll kind of pick on doctors for a second, for a doctor to say, well, I'm doing this because it's defensive medicine, I might get sued. But the fact is the doctor owns the lab and the x-ray machine too. It's not a simple thing to say they're doing more to protect their rear ends. Well, there's little checkbook action in there too, how do you tease that all out? So that's a big question. But I think we need tort reform, no question.
Part of it is that what do you pay now for OB malpractice?
Well, I was paying, I think, $24,000 or $25,000. It's really cheap in this state.
$25,000 a year just for malpractice insurance.
But excuse me, Bill, but like in Florida, it's $200,000.
Yeah. Okay. So that answers your question. Whether, and I don't disagree with what Chuck said, but that aggravates the system tremendously because you always divide the number of deliveries into how many babies you have to deliver. And if you're going to get paid, how much for a regular delivery now? $2,000-3,000 something.
I don't know.
And, whatever, you'd have to deliver a lot of babies just to cover that malpractice premium. So that's where you get that discussion. Now, if they cut back on those awards, would that affect that too much? Those premium rates? I think that's what you're saying. You don't really know.
Yeah, I don't know.
Probably don't know.
Jenny?
Dr. McKenzie kind of.
Speak up really loud. I want to hear that big voice of yours.
Okay.
Old school administrator, you can yell.
Dr. McKenzie kind of already addressed this with his remarks about coordinated care and having the doctors and the insurance component all under the same roof and how things can be better coordinated and make a lower cost that way. So that's partly answers my question, which I'm wondering if the Affordable Care Act, taking the big picture and the long view, doesn't offer us an opportunity to try out some of these cost-saving measures, which could then be switched over to Medicare, because then you've got a model to build on. And my concern is Medicare. I am 78 years old, and I don't know how many years I have left on this earth, but I'm not going to end my days hooked up to a lot of tubes and getting all sorts of unneeded procedures done and prolonging my suffering and not looking at the quality of my life. But I read the last analysis I saw of the Medicare costs. I believe it was over 50% of the Medicare bill, and that's billions and billions and billions of dollars are spent on people in the last 6 months of their life. Am I right about the analysis? It's over 50%.
30 or 50, but it's a lot. I'm not sure.
Okay, I
the
rest my
number, But
case.
it's huge.
That's the problem. Medicare is the problem. If we had all that money to spend on our schools, we could be really competing with.
But see, again,